IBD and how do you orient the conversations with your different patients. You can also register to save your place for our webinars, Mediterranean Diets for IBD, Mediterranean Diets for IBD, which will be in January 18th to 2024. Both events will be bilingual in French and English. And now let's start the presentation. I have the pleasure of presenting the conference speakers today. And so, first of all, we have Dr. Colette Deslandres. She is the director of the Department of Gastroenterology, Hepatology, and Pediatrics Nutrition at the CHU, St. Justin's of the University of Montreal. She is also a clinical professor and director of the Inflammatory Bowel Disease IBD programs at CHU St. Justin. She is the author of an educational chapter on IBD and ostomies for the Crohn's and Colitis Canada, promoting access and care through Centers of Excellence at PACE networks. We also have Dr. Frank Schwenter, who will be presenting today. Dr. Schwenter is Associate Clinical Professor at the University of Montreal and member of the Digestive Surgery Department at the CHUM, with an active focus on oncological, colorectal surgery and inflammatory bowel disease. He also has a specialization in digestive oncological surgery at the McGill University after postdoctorate research in Toronto. We received also Chantal Leduc. Madame Leduc is a clinical nurse specializing in enterostomal therapy nurse for pediatrics clients at the St. Justin University Hospital Center, CHU. Expertise in the field of wound and ostomy care. And finally, we have Marc Rouleau giving a presentation on our section for the experiences that have been lived. Comes from St. Margaret, Quebec, diagnosed with Crohn's disease in 1994. Hospitalized several times and underwent several surgeries, including a complete colorectomy. Valued mentor in Crohn's and Colitis Canada Gutsy Self-Help Program. Actively involved in his region community, leads a fulfilling career and indulges in his passion for skiing. His life is marked by his determination to surmount the sickness and inspire other people in similar conditions. We will now start with Dr. Deslandres. The presentation will start now. Hello, everyone. So we will present tonight on surgery, ostomy for Crohn's disease. And it's a small course, 101 course, a flyby of the ostomy surgery. So the next slide, please. And so we have a little questionnaire for you. So how would you evaluate your current knowledge of surgery for Crohn's disease and ulcerative colitis? 0, not at all knowledgeable, and 10, extremely knowledgeable of the subject. So,
knowledge of surgery for Crohn's disease and ulcerative colitis, 0, not at all knowledgeable, and 10, extremely knowledgeable. Je pense qu'on va faire la prochaine aussi.
I think that we'll do the next one as well. Yeah, okay. Oh.
Je crois que Lucie doit nous donner les réponses, peut-être, non?
We will get the responses right now.
Je vais commencer alors. Donc,
and so, this evening, I would like, first of all, to name a few generalities We think that they get to talk about surgeries, a bit about these inflammatory bowel diseases. I'll explain in which situation the gastroenterologists will, and I will finish with by giving you the statistics we have right now on the probability of operations for these inflammatory sicknesses right now. And so quickly, the classification of these, we have to say that the Crohn's can be manifested from the mouth to the anus. And it could be that a patient have a perianal manifestations and oral ones, but a manifestation that is most frequent, the localization is most frequent, that will be for the little intestine, the beginning of the colon. Ulcerous colitis affecting the colon, on a more rarely the thermal part of the small intestine. Pediatric, especially for the small one, below 6 years old, especially have colitis, all the colon. When we have a colitis, it will affect the colon more rarely at the terminal part. And that colitis, we have not succeeded in putting it in Crohn's or colitis. So it is not classified. It is a third possibility. Next one.
Donc, il faut aussi souligner que l'incidence des maladies inflammatoires intestinales augmente partout dans le monde et ce n'est pas seulement un problème qu'avant on ne les diagnostiquait pas. On a vraiment beaucoup plus de maladies inflammatoires et le Canada est parmi les pays avec le plus grand nombre de maladies inflammatoires intestinales. Prochaine diapo. Donc, juste vous dire, les prédictions des maladies inflammatoires en 2030 au Canada, c'est qu'un patient sur 100 aura une maladie inflammatoire intestinale. Et vous voyez, selon ce graphique, les différentes provinces du Canada. On voit que la Nouvelle-Écosse est toujours la province où il y a le plus de maladies inflammatoires intestinales. Prochaine diapo. Donc, ici, c'est le rapport sur l'impact des maladies inflammatoires intestinales au Canada en juin 2023 par Crohn Colitis Canada. On voit qu'en 2035, 470 000 personnes seront atteintes de maladies inflammatoires intestinales au Canada. Prochaine diapo. Donc, on n'y échappe pas en pédiatrie. 25% des maladies inflammatoires intestinales vont se développer pendant l'enfance ou l'adolescence. Et l'incidence des maladies inflammatoires pédiatriques est la plus haute au Canada et en Europe du Nord. Alors, ça m'arrive à parler dans le vif du sujet. Donc, maintenant, quand est-ce que je vais demander un chirurgien pour mes patients avec maladies inflammatoires? Alors, il y a différentes possibilités. D'abord, quand la maladie est réfractaire, donc ça veut dire qu'elle ne répond pas au traitement médical. Deuxièmement, quand il y a une zone de l'intestin grêle ou du côlon qui est très rétrécie, ce qui empêche le flot normal des liquides et des sels, et ce qui va être appelé une obstruction. Troisièmement, quand il y a une perforation ou un trou dans l'intestin grêle ou le côlon. Quatrièmement, quand il y a une fistule ou un trajet anormal qui ne répond pas, qui s'est formé puis qui ne répond pas au traitement médical. Et finalement, quand il y a des changements précancéreux ou des cancers qui ont été diagnostiqués au niveau intestinal. Donc, on va reprendre chaque possibilité une par une. Je voulais juste vous dire que quand la maladie est réfractaire et qu'on considère une chirurgie, quand c'est possible, on veut toujours pouvoir faire une réévaluation endoscopique et une réévaluation par entéro-IRM. Donc, la prochaine diapo, on va d'abord faire la situation où la maladie inflammatoire ne répond pas au traitement médical. Alors,
so here we will talk about when the inflammation disease does not answer to the medical treatment. So we have the colectomy and ileostomy. So what are the emergency situations where we don't have time to think about it. So the situations are when we have a perforation or hole in the colon or a toxic megacolon. The colon dilates abnormally and is on the verge of perforating or of getting a hole, and the general condition of the patient deteriorates rapidly. And finally, if we have uncontrolled bleeding. So these are emergency situations where the surgeon will quickly have to act. Next slide. So the other possibility is when the ulcerative colitis does not respond to any medical treatment. And here we can call a colectomy with a planned ostomy. So there is a date, etc. So when there is no response to the medical treatment, or when we found a dysplastic changes or a cancer. So what will happen with the Crohn's disease is when we'll ask for a surgeon is when the patient does not respond to medical treatment. And since the Crohn's disease can be a little bit everywhere in the small intestine and in the colon, the surgery will depend on which zone is affected. And I'll let my colleague discuss each different surgeries and procedures that are possible in these cases. So the second possibility is that there is an obstruction. So what is an obstruction? Once again, is when an area of the intestine or colon is severely narrowed, preventing the normal flow of liquids and stools. So on this slide, you can see an obstruction in the small intestine. We don't see that very much in the modern era. We see more on enteroIRMs. So you see there is a very restricted area, a grape intestine level, and it can cause major digestive problems or issues. So next slide, here is the situation. We have an example of a 28-year-old patient with Crohn's disease affecting the 5 last centimeters of the terminal ileum. So that is the end of the small intestine. So he comes to the emergency room, complains of severe pain in the right iliac fossa and accompanied by incoercible vomiting. He's already had 2 similar episodes which resolved spontaneously, but this time the episode persists. He ate popcorn and the corn obstructed what was left of his small, narrowed intestine. So he is going through intestinal obstruction and he will need surgery. So the third possibility is that there is intestinal perforation with some abscess in the abdominal cavity. So here we could see a hole in the intestine and there could be some stool in the peritoneal area and we can have an intra-abdominal abscess. So here I could show you a teenager that we've seen recently. She's a 15-year-old female and she presents severe abdominal pain for 3 days. Her temperature is 39 degrees. She is unwell and vomiting. She walks with difficulty leaning forward. And during her ecography, we find an abscess in her lower right abdomen. And alongside, we previously announced that she has unrecognized Crohn's disease. So this is a classical case. So in this case, what happened is that there was perforation, probably a fistula that went into the abdominal cavity and has some stool, and it's secondary to the perforation of the small intestine.
Refroidir la patiente avec des antibiotiques.
So what we'll do is we'll give the patient some antibiotics and we'll ask an oncologist to maybe do abscess drainage if that is possible. And once everything is cooled off, we'll try to define the extent of the Crohn's disease with the Scopy test, etc.
Elle ira ou n'ira pas en chirurgie.
So depending on the situation, she will go for surgery or not, depending on the treatments that are offered. And finally, or lastly, we have fistulizing disease. So we can have internal fistulas that will connect the intestine to an internal organ. For example, we can have fistula between the intestine and the bladder. In this case, we could still have, we can even have gas during urine. We also have external fistulas that connects the intestine to the skin. The most frequent are perianal fistulas. So in all fistulas, these are the most common at 55%, 55% of all fistulas. So in this case, we will also assess if these fistulas do not respond to medical treatments with biological agent. We will ask for a surgeon's help. Next slide. So, which brings me to the end of my presentation with the risk of surgery by year of birth. We have studies that have been done recently. Here you could see different graphs showing Crohn's disease, and we have different cohorts depending on the year. So you can see that from 2000 to 2017, there was a lot less surgeries, and the biological medication has increased during the years. So here for the risk of surgery, this is the same slide, but I have divided it between the risk of the first surgery in 5 years. So between 2000 and 2004, we had 20.4 surgeries after 5 years. And in 2014 to 2017, we had only 13% of surgeries. So almost half of the surgeries. So this is a very encouraging number with the number of treatments that are newly made available. And here we have the risk of surgery before and after the 2000. This is a recent article or publication. So we show here that before 2000 and after 2000, there was a reduction in the number of surgeries. So if we look at after 10 years for the ulcerative colitis, it was 4.8% for 1 year and 9.5% for 5%. So for the Crohn's disease, it was 46.5% before 2000 and 26.2% after 2000. So within the years coming along, we've had new molecules and they are very promising. So now I will pass the microphone to Dr. Schwenter. Thank you very much. Good evening, everyone. And first of all, I would like to thank Crohn's and Colitis Canada to have given us the opportunity to share our knowledge with you and our experience with you so that we can answer your questions afterwards as well. So as with the previous presentation, we have a small survey for you.
Quel type d'intervention chirurgicale avez-vous subi?
Okay. So our question is, which types of surgical procedures have you undergone? So you could choose the G pouch, colectomy, ileoscopy, laparoscopy, permanent ostomy, stricturoplasty, ball resection. Others are none. So now we're going to go through these different techniques. Of course, we won't be able to go in depth with each and every one of those, but we would like to show you different modalities and surgery approaches for inflammatory diseases. So now you have answered, and we see that most of you have either had a colectomy, ileostomy, or bowel resection that is close to colectomy. So I think you have good knowledge of resection. May it be the bowel resection or the colectomy and the ileostomy, which we will be speaking of. So for the next slide, we'll quickly look over this information. So there are different indications that lead to surgery. The decision is always made in collaboration with our gastroenterologist colleagues. And we give joint support to our patients. So we have symptomatic chronic inflammatory stenosis. So there is the restricting of the intestine. And so it's chronic, asymptomatic with pain and presents surgical treatment. So we have abscesses that are unresponsive to medical treatment, fistulas, which is the communication or the connection between two empty organs, so the small intestine and the big intestine, or the intestine with skin or perianal region. So these are trajectories that are non-anatomic. They were formed by the inflammatory response. Then we have perforation. We've talked about that. So there is a hole opening up because of the inflammation. And lastly, we have disease refractory to medical treatment.
Les indications chirurgicales peuvent se recouper.
For ulcerative colitis, surgical indications could be close to the Crohn's disease, but there are specificities. So perforation is similar, but something that is specific to the ulcerative colitis is severe bleeding through ulcers that can lead to the blood vessels that come to bring blood to the mucus. So it's within the big intestine, and it erodes the wall, and so we also have the dilation of the big intestine. There's inflammation, and it can lead to general discomfort. And so it's a generalized physical pain and brings to surgery that is in most cases an emergency. So we have the fulminant colitis. And it's rapid development with infection and with no rapid response, and this is an emergency surgery as well. So we also have disease refractory to medical treatment, so neoplasia, so for precancerous and cancerous lesions. So next slide. So before the surgery, it would be ideal to have be prepared so that the patient can well take in the surgery and also recuperate from or heal from the surgery. So these surgeries are elective and planned. Of course, we do not have time to proceed to surgery preparation in cases of emergency. But if time permits us, we can program the surgery, and we need to optimize certain factors, for example, fluid balance. So all fluids, if the patient is dehydrated, we must rehydrate them to preserve different organs, mainly to preserve the preserve the liver. We have the electrolyte balance. When there is a lot of vomiting and diarrhea, we need to rebalance the electrolytes. They always tell us to drink salty drinks so that we can recuperate in terms of potassium, sodium, and different electrolytes to enable good function of the organs. And also nutritional intake. As you know, so the intestine absorption can have an impact on the nutritional levels. So patients can be depleted nutritionally. So it's important to have sufficient supports, and if we cannot do it through the mouth because there is not enough absorption through the intestines, then we use parenteral nutrition. So this is caloric intake through the the valve. And then we have correcting anemia. If the patient is bleeding, they have a high risk of bleeding during surgery, so we need to correct anemia rather than having to give an emergency transfusion. So as for medications that are administered for inflammatory disease, certain medications are not as compatible for certain surgeries, or they have a risk of complications. For example, glucocorticoids or corticosteroids. These are a class of inflammatory medications that can have an effect on the complication rate after surgery. But for the biological class medications that we spoke of, which are now been on the market for over 10 years, these are the most common treatment for inflammatory disease. There was a lot of speculation done on the necessity or not to stop them before the surgery. So as of the last recommendations from the experts, it seems that they recommend that it's not necessary to stop the intake of these biological medications before surgery. So still in the spirit of preparation before surgery, we need investigations. We need to know which parts have been affected, which parts need to be removed. So we will do an endoscopy. We need a complete file with investigations that you can see the insides by coloscopy, endoscopy, or general imaging through abdominal pelvic CT scans and TERO scans. This works with contrast liquid that enables to highlight some restricted areas. We have the MRI. So this is for the rectum, and for children, we have entero MRI. So what are the surgical procedures? So as you've seen in the initial question, or the first question that we asked you, there are a great number of surgeries, and we can use a certain type of surgery depending on the type of disease. So for Crohn's disease or ulcerative colitis, we have different types of surgeries. So depending, for perforation, we have emergency surgery. Most of the time, it's an emergency surgery. If it's a small perforation or a small abscess that could respond well to an antibiotic treatment or a radiologic drainage, through imaging control, we can avoid surgery. But if it's a bigger perforation and that we are at high risk for peritonitis or generalized infection that can threaten the life of the patient, we need to go under surgery and remove the affected area, the affected segments. So depending on the extent of the disease, we will decide if we reconnect the two parts after removing the segment that was removed. So we have an anastomosis, so a junction between the two parts left. Or if the risk is too high because of the inflammation levels, which can lead to a new peritonitis after the surgery, then we will decide to connect one piece to the skin. We'll do ostomy, so we will connect a part of the intestine to the skin, so there is no risk of junction that eventually would not heal well and re-perforate. So for abscesses, we have antibiotics and radiological drainage or surgical drainage, with or without resection in the same operation. So it's the same idea of what we were saying with the perforation. For fistula,
à l'inflammation.
We said that it was a condition caused by the inflammation between two organs. So there could be a resection of two segments that are touched by the fistula and of the fistula herself. And we can decide to reconnect the ostomy. And when we talk about ostomies, it could be temporary so that the inflammation and infection subsides, and then we will reconnect in more secure conditions. So the perianal fissure or fistula is the most frequent. So the goal is to drain this fistula, drain all abscesses that are the origin of these fistulae, and then we do the seton. You probably heard about this term. So the seton is either an elastic or a piece of thread, like you can see on the image here on the right, and it enables the opening to stay opened, and then we can use medication to try to heal this inflammation without having to perform extra surgeries. And it could be quickly debilitating for the sphincter in the rectum and the anus.
Or surgical procedures in Crohn's stenosis to not do their resection, to remove too much of the intestine, because the Crohn's disease is a chronic disease, as you know, and it could show a repeat over a lifespan. By principle, we have to save, if you will, the maximum of intestine, not to be found in a situation near the end of life where we've removed so many little pieces that there's no more possibility of absorption by what is left in the intestine. And so one of the modalities is circuloplasty, what we see in the image here. The place that gets smaller is to open up in the length the segment that is shrinked, and afterwards to suture it to 90 degrees, and in that way, as you see in the image in the middle, in the last image, that permits to increase the volume and to increase that zone, that zone that's restricted. And so there was no resection, and so it's minor restrictions. There could be a resection if it's a short segment or stenosis that are so close one to another that they're doing a number of successive circuloplasty would be problematic for bad healing. So we remove the segment that is affected. And for the malignant neoplastia, so total colectomy versus prolectomy. Proctolectomy is to remove rectum and colon, or where it is situated, the lesion or the lesions, and afterwards, after that resection, to do or not a junction, that is to say, to bring them together for the refractory inflammation and resection of one segment, and we put end to end. And for fulminant colitis, it's a total colectomy with a terminal ileostomy, as I've said before, that we will not be able to put skin to skin because we're in a situation, an urgent situation of inflammation is generalized and infections. There's other risks of putting end to end for the healing of the suture. And so we put the segment of the intestine to the skin and let it be calmed down to eventually come back and put back end to end ileostomy terminal. Next slide. After surgery, we always have to keep in this at mind that surgery is not a cure for Crohn's disease. You know that already really well. So we treat one of the manifestations at the moment of the surgery, but it does not liberate them most of the time to continue to treat the Crohn's disease in its systemic attack to the body. What is the reoccurrence of Crohn's disease after surgery? Well, some studies have indicated endoscopic that we can see endoscopy up to 80%, which doesn't necessarily mean that we'll need to have another surgery, but it indicates that the disease is always present, that it necessitates most of the time to continue medical follow-up. And when we see it endoscopy, it's not necessarily to say that patients have symptoms. It is an image only that shows that there's inflammation. For the reoccurrence, the clinical reoccurrence is what the patients feel, the symptoms of pain, occlusions, symptoms of digestion problems. It's up to 10 to 15% per year of a reoccurrence. So there's a necessity of assuring up the follow-up, clinic, biological, blood verifications, psychological, also bearing with the therapist, to make sure that the patients are well followed by all the teams that are taking them under for this disease. Next slide, please. So surgical procedures, ulcerative colitis, as we see for the indications here of Crohn's family, there are certain specificities as when the colitis concerns the rectum, and they could go ahead. An urgency, total colectomy with a terminal ileostomy. And we remember that in that urgency, most of the time, putting end-to-end, and afterwards, subsequently, completion of prostatectomy and do a reconstruction with the pouch, the J pouch, which is the J pouch, and we'll finish with that. Elective, well, there's many different ways of proceeding. So the proctolectomy with the terminal ileostomy, putting the little intestine to the skin or directly to the J pouch that we see in the images in the middle and on the right, to create a new reservoir that will replace the old reservoir from the rectum to permit an accumulation of to reduce the frequency of the episodes.
Le rectum est relativement préservé et c'est le côlon qui est plus atteint.
Preserve the colon and preserve the rectum and put the small intestine on the rectum. We don't have to do the J pouch reservoir because the rectum is still in place. So in that operation of a J pouch, it can be done in 3 steps. There are questions that will come up with that, whether it be removing everything, proctolectomy, and doing the J pouch directly. So that's one phase. If it's in 2 phases, it's the same thing, but doing ileostomy and doing to protect the new pouch, not let the stools go through it, the ileostomy just above, so that the stools go through the skins, or in 3 phases. We remove the rectum and the colon, and we do terminal ileostomy, the little intestine to the skin. We return to the J pouch with another ostomy, liberate, as I said, and then we will close up that ileostomy. And there can be 1, 2, or 3 phases according to the severeness of the disease and the state of the patient. Next slide, please. For ostomies, and we've already spoken about it in the last slides, but the principle, as I said, is to divert the elementary bolus, intestinal liquid stools, through an anastomy junction between the segment of intestine and the skin at the level of the abdominal wall, either temporarily or permanently. So here we can see it, ileostomy, so the small intestine at the end of the small intestine, or colostomy, it's the big intestine. So we'll come back with on the aspect of putting it together. The next slide. The ostomies, so terminal ileostomy could be terminal, segment of the intestine that goes directly to the skin, or if it's in a loop ileostomy, as we go do a loop to the skin. Then we open the part that comes from the mouth and the part that go farther into the intestine. And in that way, it's two little orifices. There are, farther than ileostomy, a blockage. Well, it will not fill up and go back. So the next slide. For the colostomy, it's the same principle, terminal end colostomy or loop colostomy. You could see what I was explaining before with this loop that's brought to the skin and the two parts of the intestine that are opened up and that will permit to decompress the intestine. And after, there's a possibility of closing them up again. Next slide, please. I've finished, and I will give the mic now to Chantal. We'll take the next part of this presentation with the STEMIs. Thank you. First of all, I would like to thank the Crohn's Colitis Canada for the invitation to speaking for the role of the nurse in the multidisciplinary team, because we know that the patient needs to have the support. And from the team, the gastroenterological surgeons, we are a huge team to support the patients in that way. And in my presentation, you will see that I will talk a lot about the space, the psychological adaptation in living with ostomy. And so what is the role of the nurse as a therapist? Before, it's to consult and it will meet the family and the person having the disease of the intestine at the opportune moment. And it's always at the request of the surgeon or the gastroenterologist to plan an operation, whether it be ileostomy or colostomy. These meetings are generally planned ahead, pre-operative meetings for the localization of the future site of the ostomy, and post-operation for the teaching of the cares and the follow-ups, punctual follow-ups during those meetings with the surgeon and gastroenterologist. Meetings, the first meeting consists in getting to know each other, first of all. So it's important to let that person express themselves on their condition, and talk about their story, how everything started, the fears, the worries, the disgusting things, the fears on to be able to respond to the questions and preoccupations of that person suffering of those inflammatory diseases. And in that way, and those of the loved ones, discussions on the impact of the surgery on the activities of daily life, adaptation, physical adaptations, choice of clothing, exercises, sports, changes that are possible in sexual activities and nutritional activities. The explanations of STEMI, illustrations, diagrams that are given, how to do how to address the situation, the frequency of the changes, the equipment needed is also shown. We also talk about the cost of the equipment that is not banal, and the help, provincial help for the equipment. Every province has their own program, help program. So for those that live in Quebec, financial help is given once a year for the people that have ostomies that are permanent. We will come back to the slide. We're always at the first slide. I have a lot of text. And so once a year, the patient that has a permanent ostomy will receive $1,300 And for a temporary stomach, it's $921. And I can tell you, and obviously for those that had assisted to this presentation that are ostomies, that you know that the products for the cares are quite onerous. And afterwards, we give a list of resources and distributors for the purchase of the equipment for the future patients of ostomies. And as we said before, the ostomies that are temporary, so the surgeries become a solution for more than one problem. That are the pains, the urgencies to go to the bathroom, blood in the stools, fatigue, absenteeism, and we could name a few more. Different factors influence the adaptation to ostomy. Reactions will be different if the surgery was planned versus if it was done as an urgency. The age of the person also has an influence on the level of the adaptation, as the social help and the capacity to take care of yourself. There are less surgeries for the inflammatory intestinal problems because the treatments are more and more effective. That being said, those surgeries constitute another way to treat in the management of Crohn's disease or colitis. And afterwards, when the person has come back home, we make sure that there's phone calls, follow-ups in the external clinics, which gives a support to the new person. You work closely with the surgeons and gastroenterologists for the well-being of the patient. So we could go to the next slide now. For autonomy in the care, it starts by hygiene care, showers or bath with or without the equipment is possible and is strongly recommended. The equipment will remain dry. It will not fall in the shower if it was installed adequately and emptied beforehand. After the shower or the bath, a dryer or a towel at low temperature will help to dry the bag. We regroup the equipment to start the teaching of the first change of equipment that is done step by step, once by the therapist or the nurse to show the technique. And the next times with the participation of the person that is awesome and the help of a person that is a close loved one. Changes are done at a frequency at 5 to 7 days and more if the presence of fecal matter. This is when we change the equipment as soon as there's a leak to there not be an irritation of the skin. It's recommended to empty the bag once it's at a third to not have it be too heavy and then become unattached. It will be more discreet if the bag is emptied frequently. Plan a routine for the change of equipment. For example, the morning after taking the shower without the equipment and before eating to not have the intestine in function during the change. And that's a principal reason for the patients that have ileostomy. If it is possible, discuss with the employer or the management of the school the possibility of having access in all times to a private washroom. We can change. So the adaptation will be done progressively and differs from one person to another. The person loses control of their functions of elimination. The way to evacuate the stools need a new learning curve of elimination. His personal image is modified in the view of the ostomy and in his view, and so there needs to be a period of adaptation. You have to then respect the rhythm of every person, individual, encourage, let them express themselves. The respect that can be manifested by the listening attentively in of the entourage or of the person that is significant without judging or either taking decisions in the place of the person that has the ostomy. Let that person express themselves and respect those feelings. They can vary from one day to another. The disease is a situation that is stressful, and the add of the ostomy in the equation can be a shock that will need an adaptation from the person that has the ostomy and their entourage. Adaptation is facilitated when the person feels okay about themselves and are able to speak about the situation with people that they trust. They could also have reactions, emotional reactions that are normal, and where the important is that for that network of support. And sometimes the psychological support that can facilitate the adaptation period, or to speak with someone that has the ostomy, even though there are not two cases that are the same. Help groups or associations that can also be a great support. To give ourselves setting goals like taking up these activities that were put aside during the acute phase of the disease, and to start gradually the everyday activities that socialize and eventually practice the sport. Gradually, with time and confidence in themselves, the people that has ostomy will have less and less apprehensions and will be able more and more in control of their life. It is possible to have a great life and have an ostomy at the same time. We can change slides. No restrictions on traveling with an ostomy. They could have that objective of traveling. It is an objective that is really stimulating. There's no limitations to travel with an ostomy, but you have to prepare sufficient material for the duration of the trip and up and beyond the time of the trip. It is recommended to bring make sure not to put it in the travel case that's going under the belly of the plane, but to keep it on themselves because some of these products do not resist to the cold temperatures. But then note that the pressure of the air in the plane could bring gases to those that are in the plane, including those that have ostomies. Plan for hydration and make sure that the gases can come out, and restrain the foods that can bring gases. So all the beans, we could keep that when you land and plan to have a great trip, but not before takeoff. All drinks, gas drinks, beers, milk products, and bubble gums will generate gas. So we will try to take them with moderation. All travelers should also hydrate themselves, especially for those that have ostomies and patients with ileostomies. We know that the stools are much more liquid. And if we are dehydrated, obviously we have excessive loss of waters and electrolytes. And there it is important to always have a bottle of water with ourselves when we're traveling. Having your own possession, also a proof that you are having an ostomy, be able to give yourself the right to bring the equipment with yourself. So it could be a detail, but it's a detail that's quite important, and it will prevent worries to be searched. We could change the slide now. And not neglect an important aspect in the life of a person, which is sexuality, and their preoccupations concerning the appearance of the ostomy, the odors, the noise, the potential of leaks, and physical changes that can contribute to a lack of desires temporarily. The image of our body image can help to appreciate their sexual life, to be able to facilitate the closeness that the persons are encouraged to discuss clearly and openly with their partners. But the situations that create a shy situation, a few ideas that will help to shower, to perfume, and to put a new equipment and to cover it with the ostomy cover can also facilitate the intimacy. cover ostomies are available in different centers of ostomy centers and even easy of access on the internet. And once again, you have give time to the couple to adjust. And the last slide, you change it. Living with the ostomy requires an adaptation. You feel like an up and down roller coaster, highs and lows. There are sentiments that are temporary for the majority of the people. It is possible to live a life with an ostomy, and the only limits are those that we imposed on ourselves. So thank you very much. And I pass the mic now to Mr. Rouleau, who will do his testimonial.
Merci, Madame le Duc. Alors, bonsoir tout le monde. Mon nom est Marc-François Rouleau.
Thanks, Madame le Duc. Hi, everyone. My name is Marc-François Rouleau, patient. I am 59 years old and have had Crohn's disease since 1994. Been married for 38 years, have 2 children. I live in the Laurentians, and I'm involved with Crohn's and Colitis Canada as a mentor in their Gutsy Peer Support Program. They told me to not speak so fast, so I'll try to slow down. But my journey with the disease began with abdominal cramps, for which a doctor prescribed Zantac initially for heartburn, as you know. At the time, I remember I always had abdominal cramps, and I said, it's funny, it doesn't hurt up here, but it hurts only down here. So at that time, I was working out with the swimming lifeguards, but I was losing weight significantly. And I said, swimming is so good for losing weight. But then I realized that I had an abscess. So I thought, okay, maybe I sat somewhere that it was cold. I was not aware of that, but I was hospitalized. And the surgeon told me that there was a Crohn's disease potential. So at least I was happy to know what the problem was with my stomach, why I had pain in my stomach, but I did not know what the Crohn's disease involved. So I had a minor operation to treat the abscess, and it was followed by an appointment with a gastroenterologist for a colonoscopy, which confirmed the diagnosis of Crohn's disease. I was prescribed prednisone, cortisone, to manage the symptoms. I had beautiful cheeks. And then was the start of a very difficult period. Sometimes I could not even drive my car, marked by weight loss, difficulty tolerating food, frequent visits to the toilet, and frequent vomiting almost every morning. And also I was a sales lead. I was on the road with my employees, so I can tell you that I am an expert in bathrooms and locating a bathroom in Montreal. But I have a friend that noticed that I had a hard time walking. I had inflammatory arthritis, and I started doing water retention. She said, something's not working. Maybe you don't have a good follow-up. So go to Hotel Dieu emergency room, where they have specialists in inflammatory disease. So my spouse drove me to the emergency room, and that is where I hope I won't get emotional here. I apologize if I do. These are old memories. So at my arrival at the emergency room, I felt that I was taken into good hands. I was so happy that I was crying with joy. So that's where I met with my specialist, Dr. Raymond Leduc. And that marked a positive turning point in my life. It transformed my life. So his confidence and reassurance gave me hope that I would find an appropriate solution to ease my suffering. When you want to do sports and your stomach hurts, it's tough and it's rough. But after 2 weeks of treatment, I was able to regain some semblance of health and return home. But shortly after my discharge from the hospital, there was a discovery of an anal fistula that led to another operation. They said it was a result of the Crohn's disease. So I got meshes. For those of you who know what those are, when you remove them, oh my God, it hurts. But even there, I keep a positive mind and I continue to persist, even though if I do have cramps and cramps and cramps. So my doctor recommended another colonoscopy and a CT scan, which revealed a microperforation in my colon. There you go. I knew something was wrong. And another surgery was called for with the possibility of having to remove part of my colon. That's when I realized the importance of a colon. And they talked to me about the need for an ostomy. And that's where I was educated on that. And what Madame Leduc presented earlier, well, I've had that meeting. I had the meeting with the nurse. I had the meeting with the psychologist. I can still remember the syringe with the ethylene telling me where do I put my bag, how do you place your pants, how do you clean it up. I am a very positive, optimistic guy. So if that can heal me, well, go ahead. Dr. Leduc, I trust you, and he's a very competent surgeon. And my spouse was really agreed with it. So we said, okay, let's move forward with this. The meeting with the technical and medical team was very comforting and exceptional. I trusted them and I knew that they knew what they were doing. So in the end, I was operated. I got a colectomy, so no more colon, but there was no infection, so we didn't have to get an ostomy. But I learned so much and it didn't matter to me. All I wanted was to stop suffering. So I've been with my wife for 38 years now. She loves me and I love her. And I said, okay, I'm going to heal and that's all. But it did affect me after all, psychologically. In 1994, it wasn't really fun. And then I spent 2 months recuperating or healing in the hospital. As soon as I got my surgery, I found back my quality of life. I started doing triathlons again. I started going into politics again. I had a few hospitalizations afterwards. My surgeons are not always happy with me, but sometimes the food wouldn't go by anymore, and I liked eating peanuts and popcorn, but that was not a good idea. But I loved those foods so much that I had to get surgery again in the Canary Island. I was hospitalized also in the Saint-Agathe Hospital at the City of Health. So I learned from my mistakes, but they would put through a small balloon to increase the space, but now I no longer eat popcorn or peanuts. But it's truly remarkable how much I feel better now. And these modalities and techniques really helped me. I was taking a maximum dose for many years of lidocaine, and now we've changed for Stellara. I don't know what's that molecule, but it works well. And I can tolerate it in my case because I remember I had friends in the same room with me for the Crohn's disease. One was operated and the other not. So I trusted my medical team. I trusted them and I trusted the nursing team. But I've went back many times. I'm going to be emotional again. Hold on. So that's it. It just hit me. Sorry. But when you're well surrounded, you feel good. And I will finish with this. I said this to my doctor earlier. Today was my first time that I was self-administering my Celara medication. In my stomach, I was stressed out. I never did it myself. I always went to the hospital for that. It wasn't so complicated, but sometimes I suffered so much that the thing that I wanted was to never suffer, so I never did it. But this morning I tried it. It didn't hurt, and I was proud. So that was my testimony. Thank you for giving me the occasion to do so. I'm sorry for being so emotional, but your emotions are truly appreciated. And thank you, Mark, for having shared your experience with us. This testimonial was excellent. And we are touched by your emotions. So thank you. So now we will move on to Q&A. So since we have a lot of contents to cover, I think we're going to use the time that we have left to try to answer your questions.
Ok, donc la première question posée, c'est
So the first question is, what are the potential risks and complications of surgery in IBD?
Alors, cette question m'était destinée.
So this question was for me.
Directement au niveau chirurgical.
So there are risks directly related with surgery. So once you've gotten surgery, you can have infection. Then there could be a dehiscence of the so the stitching can open up, the stitching of the wound can open up. And also if we were under prednisone before surgery, sometimes the staples or the stitches can let go and the wound will open up. So for nutrition, depending on the small intestine that was removed, we can have small complications. So the terminal end of the small intestine where we can absorb a B12 vitamin, so we can become B12 deficient. But we do have a 5-year reserve of B12 vitamins, so just think about that. If you had a resection after 5 years, you can talk about it with your gastroenterologist. And there are also the absorption of biliary acids. So this is in the terminal part of the small intestine. If it's only a little piece that was removed, there might not be too many side effects, but if we've removed the bigger part, we can have some diarrhea. And if the resection is done higher and the proximal intestine, so in jejunum, we can have a deficiency in certain vitamins like vitamin D and E, and we can be deficient in iron. And if we've had a long resection of the terminal end of the small intestines, the biliary acids should be reabsorbed, and it should help digest fats and vitamins like vitamins A and E. So eventually we can have malnutrition because we're not absorbing fats properly. So these are imminent complications due to the surgery.
La prochaine question. Comment soutenir un
next question? How can we support a loved one who is just adjusting to having an ostomy? So this question was sent to me. So this is a question that we could discuss during a whole webinar. I think I've answered this question in part during my presentation, but I would add that you should time go by, give a necessary time for the loved one to adapt to his new situation. There are many things that are modified at the physical level and the psychological level. So the person must be supported and encouraged to verbalize their concerns. And also, we must be in the listening mode and respect the moments where they need to be alone. The trust will be developed with time. It's important that the helpers are aware that it's normal for the loved one to want to be alone. We need to give them time and take the opportunity when they want to speak to talk about different things that they can do, like go to the movies or do little simple activities, go to the restaurant, and have long and short and midterm projects. And know that being there, just listening to them is already helping them. We must respect their adjusting speed. There are also groups for help, support groups. There are the Quebec Association of Ostomized People. There is the Intestinal Inflammation Organization, Crohn's and Colitis Canada. So I hope I answered the question.
Merci. Prochaine question. Comment se passe la
Thank
période
you.
de
Next
récupération
question.
après l'ablation
What does the recovery for the removal of your rectum look like?
Donc, on a vu dans la présentation des différentes modalités chirurgicales, il y a différents segments d'intestin.
Different modalities. We had to look at the situation.
Là, on parle plus spécifiquement du rectum.
We're specifically talking about the rectum, so that touch more often Crohn's, colitis, disease of Crohn's, pardon. I've indicated it beforehand. Moving the organ, the rectum, and then the reconstruction, we put the ostomy, or that we put end-to-end part of the colon or ileon, the little intestine on the rectum. And globally, after a surgery of this type, these are major surgeries. Hospital time for recuperation at the hospital, if there are no complications, about a week. If there's complications, depending on the complications, it takes more time. And then afterwards, the period readaptation outside of the hospital, which is oftentimes counts even more for the patients. The testimony of Mr. Hulot that was very touching, by the way, and it represents so many of the stories that we hear by these patients. We see that life after the hospital comes back little by little, and it's really dependent on the general state of the patient before the operation as well, according to how they were touched by the disease. If we talk about the arthritis, in this case, it influences as well on the recuperation after the rectum operation. I think what's important is to give yourselves time, not to be too much in a hurry, but to go forward every day and give yourself objectives to recuperate after that operation. Recuperation and of energy. Easily could take a month to 2 months to get back that energy and to get used to this new mode of life, what it is to have an ostomy. Chantal explained it very well. If there is a reconnection in learning how to live with these new habits for the stools, the frequency of quality of the stools, the feelings, the change after removing the rectum, according whether it be a reservoir or not. And that is also very dependent on the adaptability of every person. What was most important is to say that there are progress there is a good recuperation of the quality of life. Monsieur Rouleau is the proof of this and the reflection of it, and that we have to give ourselves time.
Merci.
You.
Prochaine question.
Next question.
Avoir une stomie
Having a
affecte-t-il mes chances de tomber enceinte?
ostomy, does that affect my chance of getting pregnant? Well, that's a great question for being pregnant after having an ostomy on the stomach. Does not prevent having a child or the growth, but the only reason is why would the ostomy was put in place, in what circumstance, and what surgery was done beforehand. And so if we have an ostomy after we've had a stomach, after an abscess, for example, in the stomach, etc., we were able to develop adherence for an ostomy for after a colitis, or if we had a surgery in the little basin, it could be developed to add adherence. So yes, it is possible, but it's possible also for the fertility that would be less fertile. And so in that case, it's in concert with the obstetrician and the gastroenterologist to see the possibilities. And sometimes there are adherences for the trombs to see the eggs. And there's a certain way to become pregnant during the ostomy, but you have to question what brought it to the ostomy. Thank you. Another question. Are there some foods that I should opt for or avoid because of now having an ostomy? Well, generally, the person that has an ostomy would be able to eat the same thing as the ordinary people, unless the nutritionist recommends a particular diet. But for all surgeries, we won't start to eat and drink as we did before after an operation. So even less when we have an ostomy. But as said during the presentation, certain foods, it can create problems. We can't control them by not eating big quantities. Like certain foods cause odors, onions, asparagus, fish, garlic, cheeses, and certain vitamins. But we can't control these odors by drinking orange juice, drink tomato juice, and by eating yogurt. Even for patients that don't have ostomy, if we eat too much garlic, we can eat a bit of greens, odor in the mouth, and those are foods that will be to privilege. But for Mr. Rouleau, we will recognize yourself a bit to not block the ostomy. It's important to eat well the foods and drink a lot of water, liquids, and to inject gradually the foods to see how the intestine will react, because the intestine has an adaptation period to be done to all the foods that will be ingested. And that's a reason for popcorn, nuts, grains, to be very careful to eat them very well. Sausage, it's very fibrous, lettuce, dry fruits, the fibrous parts of fruit, the skins of apples, different skins will need to be very vigilant about to prevent constipation to the person that has an colostomy and the ostomy, because the stools are already semi-liquid or semi-soft. So these rich foods and fibers are recommended to help the expulsion of stools, hydration by drinking a lot of water and other drinks, and to exercise. And so you are the proof, Mr. Rouleau. You do a lot of exercise, that's really good. And so what we have to remember is to have varied food without falling in excess. They are the same notes for that have known ostomies.
Merci. Prochaine question.
Thank you. The next
Je suis aux
question.
prises avec
I am
une
struggling with
colostomy et une
colostomy
hernie
and
douloureuse.
painful hernia.
Comment puis-je mieux
How can I
gérer
better
ces deux
manage these two?
Donc là, on parlait du problème précédemment de la hernie.
Talking about the
Le
problem that I was going to
principe
finish
de la
with, the
hernie,
principle of
c'est
a hernia
un déficit,
is that it's
défaut, une faiblesse
a weakness
au niveau de la paroi abdominale,
with
au
the
travers
abdominal
duquel
wall,
il y a
and
des
through
éléments
which
dans
the elements
l'abdomen qui
that
ont
are in the
tendance à
abdomen
sortir.
have a tendency to come out.
Donc c'est comme
And
on
so
appelle
it's
ça un trou, mais
it's
dans
like a hole,
la paroi qui est
but
constituée
in
par
the
les
wall
muscles,
that's made by the muscles,
les structures qui recouvrent les muscles,
structures that cover the
qui sont dans le
muscles,
ventre ressortent jusque sous la peau.
come out
Et c'est souvent
just under the skin, and
dans des zones de
oftentimes
faiblesse,
the weak
alors, il y a des
zones,
zones de faiblesse naturelles
the natural zones that are weak, and that's a natural cut that everybody has at birth, umbilical cord. Those weakness places are created by surgeries, by incisions that were done, but also by the presence ostomies that leaves a hole. It's a hole that goes through the wall, but up to the skin. And so it's not rare to see what we see a paraostomy hernia from the inside of the stomach that comes out, but on the sides of the stomach, you have the impression that there is a balloon there that is found all around the ostomy. And so it could be disturbing visually and aesthetically for the image itself. It could be a problem for the functionality of the ostomy itself. It could have put the compression, decrease the passage of the stools, but it can also have difficulties on the equipment of the ostomy. So, in addition to the pain that it causes. So these hernias that are linked to the ostomy or linked to the incisions that are elsewhere than the ostomy itself, but also in the surgery, it's the hernia that can be fixed surgically by waiting for the surgery and the systems of maintenance of support that could improve the symptoms are the straps that you could do an orifice uniquely for the stomach and its equipment, and it compresses a bit all around the stomach. It could compress the hernia itself and go more into the stomach. That is support, but it will not heal the hernia. If the patients want to have complete healing, well, in that case, it goes by surgery. It consists in going to reduce, bring back the elements that came out of the stomach and consolidate the wall and around the ostomy by different prostheses. But it's a new surgery, and when it's a surgery, it has possibly complications, but it can be done.
Ok, merci. Donc là, il reste
Thank you.
2 à 3 minutes. On va passer à la dernière
3 minutes
question.
left. Let's go to the last
À
question.
quel type de selles les
What type of
personnes
bowel
atteintes de
movements can
maladies
people with
inflammatoires
IBD
peuvent-elles
expect
s'attendre
after
à
surgery?
après une opération?
Je pense que ça venait à moi, cette question.
Well, I think that question came to me. So depending on the place where the surgery was, there'd be stools that will be normalized after the surgery, or we could have a situation, like I said before, in Crohn's, where the terminal end of the intestine, depending on the segment that we resectioned and the length of it, we could really have a problem in the absorption of the acids that should be reabsorbed at 95% in the terminal intestine and go back up to the liver. It will fall in the colon, literally, create inflammation. And we will have diarrhea. That's one of the consequences of a surgery on the intestine. And in these cases, we'll have diarrhea that are increased. We'll have pains in the stomach. It'll be secondary to those acids that come to influence the big intestine. That will cause also stimulation of emotion and a stimulation of secretion of water and of chlorine. So there are treatments for this type of diarrhea. And afterwards, depending if the patient had a surgery, rather astomose, anal or astomose with a J pouch, the stools in the beginning can be quite frequent and even incontinence as well, with a certain improvement afterwards. And so really the question is vast because it depends on the surgery, the initial surgery, the idea of putting, especially if we have Crohn's and this resectioning was short in the terminal intestine, the idea normally should go back to the stools that go back normal.
Parfait.
Merci beaucoup. C'est tout le temps qu'on dispose.
Thank you very much. So this is all the time we have for questions. So we will take the questions that were unanswered and put them up on our website. Unfortunately, we no longer have any time for questions, so I'm going to give the floor to Sabrine. Yes, well, thank you everyone for being here. If you do have any questions or if you need help, send an email to learn@crohnsandcolitis.ca. Now we have your last survey questions for today. So how would you rate your current knowledge of surgery for Crohn's disease and ulcerative colitis? So from 0 to 10.
Donc, prochain slide.
So next slide.
Faites-nous savoir comment nous étions.
Let us know how we did and what you'd like to be covered in the future events. So please take 60 seconds at the end of this presentation to provide your feedback. A prompt to complete the survey will appear on your screen directly after this. So thank you very much to BG Communications for the live English interpretation. And if you're looking for more information or support, we encourage you to see the Ostomy Canadian Society's website. You can contact them with the contact information on the screen. And do not forget to follow us on Crohn and Colitis Canada for our future programs. You can find us on Facebook, Twitter, Instagram, TikTok, and YouTube. So thank you for being with us again tonight and have a great evening.
Bonsoir tout le monde. C'est un plaisir. Bonsoir les docs.
Goodbye, everyone. It was a pleasure to be with you.
Monsieur Rouleau?
Oui, oui.
Je vais juste vous dire, c'est mon...
Mr. Rouleau, I just want to tell you, Dr. Raymond Leduc is my husband. Oh, that's you. I've heard so much about you. I've been with him for 30 years. So you can say hi to my doctor, Ray Leduc. I love him. I'll tell him. But don't put too much. Don't exaggerate. Oh, well, thank you so much. It was a pleasure to meet you.
Merci.
Bonsoir à tous.
Bonne soirée, merci à vous. Au revoir.
Au revoir tout le monde.